Some of the folks that I've worked with in my career will struggle to find senior living communities because of having a mental health condition.
Right.
And so this is where I would love to hear your thoughts and experiences in helping families who do have mental health concerns and conditions kind of look for senior living communities.
It is
So,
a problem. It definitely comes up a lot. And recently it's come up for me. I don't know if it's because of COVID. Just in the last 6 months, I've had so many cases like this. And the trick is that these people have a mental health condition, but they live a normal life. And we're not looking for a mental health senior living community for them. We're looking for how to mainstream them. It's important to prepare them and their family so that when they do move, they will be successful. And so that the community that they're moving to knows all the details and knows what they're getting so that they can help and they can partner with the family, is really how I look at it.
I'm Dr. Regina Kepp. I'm a board certified clinical psychologist and I specialize with older adults and families. I created the Psychology of Aging podcast to include older adults in conversations about mental health and wellness. And here's why this is important. When we're all a little more informed about mental health for older adults, we reduce suffering and improve quality of life. And who doesn't want that? So join me. It's simple. All you have to do is listen, be willing to learn, and then share what you learn with others so that they can be included in this conversation too. All right, let's get started. Well, Candy Cohn, thank you so much for joining me on the Psychology of Aging podcast. I'm thrilled that you're here. Can you share a little bit about who you are and what you do?
Yes. Hi. Thank you so much for having me here today, Regina. It's really an honor to be on your podcast. I've been listening to it for a while now and learning a lot from it. And it's very friendly and it's something people would want to listen to. So I really am honored to be here.
Oh,
So I'm
thank you.
Candy Cohn. I'm a certified senior advisor and I'm the owner of Oasis Senior Advisor, South Florida. I help people find senior living communities, and that includes independent and assisted living as well as memory care. And I own a franchise, so I'm part of a national company. And so it's a free service that we offer. We get paid a commission by the senior living community when we place someone. So I can, because it's a franchise, I can actually help people all over the country because I can refer them to my colleagues in other places. And I am passionate about what I do because I got into this business because of my own parents. And that was about 10 years ago. I had to find senior living for my parents, and I was lucky enough to be referred to a senior placement advisor to help us. And at the end of the whole process, I had been doing some freelance marketing at that time, mostly in healthcare. So I asked the senior placement advisor if he needed help with his marketing. And he said, actually, I'm interested in training someone to do senior placement. Would you like to do that? And I said, absolutely. So that's how I found this career. And it turns out it's my life calling. I am absolutely positive of that.
Oh,
And
that's such a great journey.
yeah, so I worked with him as an independent contractor for a while. And then 3.5 years ago, the opportunity presented itself to purchase this franchise. And I vetted the company and looked into it. And Oasis Senior Advisors just had so much to offer. Especially for me, I had never really owned my own business. I had been a freelancer, but not like owned a whole business. So I love the support they provide. And we also have a proprietary software system that helps match the senior to the senior living community. And that's really terrific because it takes me out of the picture as far as the initial matching. And then, so it's objective just based on the parameters. But then I use my judgment and my experience to narrow it down with the client.
Can you give us an overview of the different types of senior living communities that older adults can live in?
Yes. So there is independent living, which is when people just want to move into a community, maybe their house has become overwhelming, caring for it, the maintenance. Maybe they stop driving. That's often a time I get a call, or the adult children call me to say my parents shouldn't be driving anymore, and I don't want to have them just stuck at home. Oftentimes, loneliness is a really big issue. So sometimes when they just lost a spouse, or all of their friends are starting to pass away and they just can't have much of a social life anymore, that's a great reason to move to independent living. So in independent living, you have your own apartment and you're part of a community. You might have a studio, 1 bedroom, 2 bedroom, and you have a kitchen. It's a full apartment. And you are part of a community where you get there's communal dining in a dining room. You get 2 meals a day in most independent living communities. In assisted living, you get 3 meals a day. And with a lot of communities have independent and assisted living on the same campus. Most of them do. I only know of a couple communities here that are just independent living. So when there's independent living and assisted living on the same campus, they're often similar. At some they're totally different. Some places it's a separate section for assisted living, and some places the independent and assisted living apartments are kind of integrated. So either way, independent or assisted, you get your own apartment and you have the opportunity to eat in a dining room. With COVID, the dining has changed. It's been mostly that they're delivering the meals to the apartments. Although I'm happy to say here in South Florida, they are starting to resume communal dining as long as the community has been COVID free for 14 days. So that's been a really big deal here and everywhere, but it's different in every state and every location.
Are they testing the residents there regularly?
They are not testing them regularly at every community. It's not a state regulation. They were testing them for a while. They are taking temperatures at most communities, and they are taking staff temperatures on a regular basis at all the communities that I deal with.
Yeah.
COVID has definitely changed the face of senior living, but it's still a wonderful option. And I'm really pleased with the way the senior living communities I deal with have handled it. In the beginning, we were all petrified and, business just stopped for a while. The only people I was moving were people in crisis. But now people are back to wanting to move. A lot of them are really lonely because they've been stuck inside. I have this one client, she's so desperate to move. Unfortunately, her son and her doctor won't let her move yet. But she calls me crying all the time. She's like, I don't care if I get COVID. I am so lonely. Her husband passed away a year ago, and she was all set to move in March, and her son won't let her. So it's really sad, but I am happy to see that most seniors are open to it now and are looking forward to moving. So besides the dining, they have activities at these communities, whether you're in independent or assisted living. They have, people say, especially at the nicer communities, it's like being on a cruise ship that's docked in port. You get up, you check your calendar, you're going to go to breakfast, and then you're going to maybe go to morning exercises, and then go to the book club and, current events. And it's great. They make friends. And even people that don't want to participate in a ton of activities, just the meals alone are the social activities. So like for my parents, they weren't card players. They didn't do all those other activities, but just going to the meals was a really big deal. And my mother, before moving my parents to assisted living, I would go visit them sometimes and they'd still be in their pajamas, house coat, sitting around reading, cooking, like not cooking, eating canned soup and tuna fish. And my mother used to be an amazing cook. So it was really kind of depressing. As soon as I moved them, whenever I would go over there, my mom was all dressed. She had her makeup on. She even started wearing a wig, which I convinced her to do because she was so upset that her hair was getting really thin. And she got dressed and felt good every day. And that was so important. So I think that routine is so important. Because when people retire, that's often a big thing that happens. They just fall apart. They have no routine. They have no reason to wake up in the morning. They don't know what they're going to do. Some of my clients sit around and watch TV all day, and and they used to be active and vibrant. So
Right.
I love seeing people move to senior living. I think it really is a healthy situation for them. So just to go back to independent and assisted living, you are free to come and go when it's not COVID. Okay, COVID has, put a damper on that. There are different rules and regulations in place, but you're still free. It's like having your own apartment in a community. You can keep your car if everybody says that's safe to do. Uh, and you have this wonderful community. They provide transportation though to doctors and like some shopping within 10 to 15 miles or so. And they have housekeeping once a week. They do laundry of your linens in independent living. If you're in assisted living, they do all your laundry. And you can usually pay, like if you're an independent, you want to have them do all your laundry. And there's other amenities that are provided. Memory care is the next level after assisted living. So that would be for people that have dementia that is advanced enough that they need constant attention and care. And they might be an elopement risk. They
Right.
might be one to wander off. So the memory care community is either a whole community in itself, separate, or it's a separate part of a bigger community that has independent and assisted living. The memory care section is locked, is secure. We call it secure. And words are really important. I want to say that. I call these communities. These are not facilities. A skilled nursing facility is a facility. It looks and smells and feels like a facility. It feels like a hospital. These are not. These are really communities. And it's important with my clients, I tell them when you're talking to your loved one about it, call it a community.
Hmm.
They all say, I don't want to go to those. I don't want to go to the home. The home, that's what they used to call the nursing home. I don't want to go to that facility. So that words are, as you know, are really important.
Yeah, well, because it creates this sense of institutionalization, and
Right.
nobody wants to be institutionalized or incarcerated, or, I mean, that feels like stripped of rights and access and life and vitality. And of course, I really appreciate you saying that words are important and how we talk about senior living communities matters. And even the small little things we say to older adults who require assistance outside of living matters, like adult briefs instead of diapers, or and that's something simple, or an adult day program rather than adult day care, because that's very infantilizing. And so the words that we're using, talking about communities rather than institutions or facilities,
And
are
even what we call seniors, I don't think we've come up with a good word yet. Do you have a good word?
no. Ashton Applewhite, who I interviewed a few months ago, calls older adults olders.
Oh, okay. I like that.
Yeah,
Yeah.
but I agree. Seniors is not a great term. Older adults is cumbersome, and everybody ages at different rates and has a different process of aging, and so it's hard to just put everybody in one category.
Right.
So, yeah. And it's such a long span of age too. So adolescence, it's like, 13 to 19 to be a teen. That's 6 years. That's not very long. Older adults can be older from 65 to 122, right?
Oh,
And
yeah.
so that's decades and decades. That's not really fair to put everybody in one of those, in one category. But I digress. So, okay, so back to senior living. So words matter, and you've described independent living in a community, assisted living in a community, and memory care in a community. Sometimes those communities are continuous care retirement communities. Is that? Uh,
That's correct. So there are the CCRCs, the continuing care retirement communities, and those are what they call buy-ins. So you buy in, you put down anywhere from like 150,000 to 600,000 up front, and then you still have a monthly fee. They call it a maintenance fee or something like that, and it's high. I mean, it's like 5,000 a month or
wow.
3,000 a month, depending on the community. Then there are the ones that are strictly rentals, and that's what I deal with mostly, but I do deal with the CCRCs. It's just not the right fit for a lot of my clients, not just because they don't have the money, but because once you're like, 85, older than 85, I'm not sure that it's the best fit. People at the CCRCs tell me otherwise, and I'm still learning a little more from some of them, but I typically recommend a rental to people in their late 80s or older.
Mhm.
And that's what most clients want. And with the rental, you sign a what they call a 1-year lease, but you can give 30 days notice and move out. And if someone passes away, as soon as you remove their belongings, the family removes their belongings, you stop paying rent and you get back, they prorate the month if the loved one is already there. So I just think the rentals have more flexibility. With the buy-ins, that money that you put down, if you live there for, number of years, 5 years or more, your estate doesn't necessarily get back much of that money. So it's not necessarily the best way. And some of these rentals now, especially near me, in South Florida, are just gorgeous, as beautiful as the buy-in communities. So that is something that is different. And then one other type of assisted living I didn't mention is a residential care home. It's a group home that has an assisted living license. And my mother lives in one, and it's been wonderful for her. So they have usually 6 beds in Florida anyway. And there's a lot of them here, but I hear from other Oasis franchise owners that's not true in every location. So I'm not sure where you are if they have a lot of these. They're in neighborhoods, so you wouldn't know they're there. They don't have a big sign out front. Where my mother lives, it's owned by a nurse. That senior living community has an extended congregate care license. So that's another thing in Florida that is not true everywhere else. It's probably in some states. There's different levels of licensure for assisted living. So there's a standard license, an LNS, limited nursing service, and then ECC, extended congregate care. So with extended congregate care, they can handle a colostomy, which my mother has. They can handle oxygen. They can give injections. Mm-hmm. They could do a 2-person transfer if someone requires 2 people to transfer them from the wheelchair to the bed. So there's lots of complications, or complexities, I should say, which is a reason that someone should work with a professional like myself, a senior placement advisor, so you don't spin your wheels, and so you don't move your loved one into a place that's just not going to work for them, and then you have to start all over again. So those are a lot of the different types.
Yes. Well, and you're really just in the personal care home or the residential boarding care home or residential care home. I have different names. Yeah, Georgia has personal care homes, and a lot of my patients lived in personal care homes. They tended to be more affordable for my patients than assisted living communities or CCRCs.
Right.
Is that true though, Candy? I don't know much about the cost of personal care homes. Is that true, or are communities like the ones your mom lives in where there's more, is it nursing care?
No, it's owned by a nurse, but it is an assisted living.
Mm-hmm.
She does get nursing care. That is true because it is owned by a nurse. But the residential care homes are still assisted living. They're not a skilled nursing facility. So, but they are a really good way to keep people out of skilled nursing facilities. So I get calls sometimes from clients or a physician that says, my parent or my patient needs to move to a skilled nursing facility. Can you help? And after talking to the family, I realized that we might be able to avoid the skilled nursing facility and move them to a residential care home. Most people don't know about the homes, so they on their own wouldn't do that. My parents were actually in a big traditional assisted living community for years. That's how I started this journey. And then my dad passed away a few years later. And then 2.5 years ago, my mother started needing more care. She can hardly hear. She's totally deaf in one ear. She has dementia, which has progressed. She has like moderate cognitive impairment. And it was getting difficult for her. And then she actually hurt. She didn't fall, but she was bending over in the shower and snapped a vertebrae. So now she uses a walker, and she has a heart condition now that is making her lightheaded, and she started falling. So I realized I either had to hire 24-hour home care aides and keep her at the big assisted living or move her to a residential care home. So that's when I decided to move her, and it's been wonderful. There's someone always in the next room. So when she stands up, they know, and if they get to her before she stands up and she won't fall.
Yeah.
They can take care of her colostomy because of the licensure that they have. And she doesn't have to deal with large crowds in the dining room. It was getting really difficult for her at the other place because she couldn't hear, and the dementia, and she started getting paranoid. She thought people were talking about her. So for someone like my mom, the residential care home is great, and where she lives is pretty affordable. So some of them they're priced at all different levels, but they can be more affordable. And most of them accept Medicaid. So that's another thing, with the larger communities, only some of them accept Medicaid. And Medicaid will pay up in Florida, will pay up to $1,400 a month for the care, not the rent, but the care. But at a residential care home, it's just one total price. So that $1,400 is applied towards her total rather than where she used to live. We still had to pay her rent, or she did, and we had a supplement, and then the $1,400 could only be applied to her care.
Oh my
So
goodness.
residential care homes can offer more flexibility
financially for families. Yeah. Oh, thank you for sharing those options. It's so helpful for families to get a picture of that. And then just to touch back on what you mentioned earlier. So in your role, the family doesn't pay you directly. You get paid by getting a commission from wherever the family ends up. Is that right?
That's right. Yeah. I tell people I'm kind of like a cross between a social worker and a realtor.
Yeah.
I'm not either of those. I am a certified senior advisor. I do have a certification, but that's just my analogy. So the social work piece is I go in person, I do an assessment, find out what's going on with them. Then the realtor hat I put on and take them on tours of the communities. And then like a realtor, I get paid a commission by the community.
Oh, that makes sense. Then that's a helpful analogy. Yeah, you're a liaison and an advocate. Yeah,
I am an advocate. That's huge because each place I take the client to, the salesperson is doing the tour. I'm there as the advocate. So that salesperson is going to try to sell my client on that community. And I'm not. I'm there to help them compare and contrast and figure out. I usually take them to like 3 places. And I'm trying to help them figure out, okay, out of these 3, which is going to be the right fit? And I'm not telling them, it's up to them, but I guide them along the way.
And what would you say to families? So this is maybe where that assessment comes in that you do at the beginning, that's objective. Because then the question that comes up for me is, if you're getting a commission, does that mean you're only showing the high end communities? And so how do you safeguard against that so that you're helping families where they can afford it?
Well, first of all, I wouldn't take them to a place they couldn't afford. There's no reason to do that. And because I'm a certified senior advisor, I have ethical standards, high ethical standards I adhere to. I couldn't sleep. I couldn't wake up and look at myself in the morning if I was doing something unethical. That's just how I am. But I mean, it wouldn't benefit. My job is to help the client figure out, okay, your mom is 93 years old. She gets this amount of money and we need to make it last. I mean, that is my job. So yes. I would never take them to places they couldn't afford so that I could get paid more. There's no reason for me to do that. And almost all the senior living communities work with me, and even more so now because of COVID. A lot of them are hurting, and some that were refusing to work with senior placement advisors in the past are now saying, hey,
we need it. Yeah. Yeah. And I think, one, you have a moral code and an ethical structure with your CSA certification or license. And then second is your own lived experience with your own parents and understanding that your parents could start in one place and needs could change and money can change over time. And so being open to switching too. So you switched your mom when her needs changed, and
right.
And then you moved her to a different community that would be more accommodating for her, less stimulating. It sounds like she was overstimulated at the community, assisted living community, and just that it better meets her needs financially and physically, and hopefully emotionally too.
Right. And I make an effort to keep in touch with my clients periodically because they might need something different at some point as well.
Right. Yeah. Mm-hmm. Now, can you share a little bit about, since this is the psychology of aging, I do want to talk about one of the things that comes up that's come up frequently in my own practice around older adults with significant mental health concerns, like a bipolar disorder or a schizophrenia or a significant depression that recurs throughout an adult's life, and then they become an older adult and continue to have recurrent depression. or anxiety or post-traumatic stress disorder. Some of the folks that I've worked with in my career will struggle to find senior living communities because of having a mental health condition.
Right.
And so this is where I would love to hear your thoughts and experiences in helping families who do have mental health concerns and conditions kind of look for senior living communities.
It
So
is a problem. It definitely comes up a lot. And recently it's come up for me. I don't know if it's because of COVID. Just in the last 6 months, I've had so many cases like this. And the trick is that these people have a mental health condition, but they live a normal life. And we're not looking for a mental health senior living community for them. We're looking for how to mainstream them. It's important to prepare them and their family so that when they do move, they will be successful. And so that the community that they're moving to knows all the details and knows what they're getting so that they can help and they can partner with the family is really how I look at it. So my first experience with this was my own father. So my dad had bipolar depression, and he had been treated for it for many years and was usually stable, but about like every 8 or 9 years, he would have an episode for whatever reason. And like 10 years ago, he had an episode. He was in his late 80s, and it was an episode like I had never seen before. Before this, he was either usually depressed or manic. He wasn't both. This time, he was both. So, in a period of a couple hours, he would go up and down, and he was so angry. And he was depressed, and he was lethargic, and then he was hyper. What had happened was he stopped taking his meds. He didn't stop. He ran out of his meds. And he was so embarrassed because he thought he did something wrong. He didn't think it was time to get the refill. He was on an HMO, and he said he was afraid to call them. He didn't tell me. And I lived, at the time, I lived 5 minutes away from him, and he was managing their life. I wasn't managing their life, but I would have been the closest person to tell, and he didn't tell me. And then all of a sudden his behavior started getting erratic, and we found out that he hadn't slept in a week because that was how he responded to depression. And turns out he had run out of his meds. So he was out of control. And my poor little mother, and I mean, really small, tiny woman, and he was strong. My dad used to be a bodybuilder, and he was older and kind of, a little frail, but still that strength just came out. And like, he didn't hurt her. He never did anything physical, but he would like block the doorway, and you couldn't move him if he didn't want you to go out. So I started trying to get him into a mental health hospital. And I couldn't there was no bed available at the local place. I called every day, and I was making all kinds of calls trying to figure out what to do. Finally, I called a hospital where he had been like 10 years prior to that. He actually had ECT treatments 10 years prior to that, and they really helped him. So I called to see, could we get him into the mental health facility there? And they said, do you have beds? They said they do have beds. I said, well, how do I get him in? They said, just bring him to the ER and we'll get him in. So I brought him to the ER, and it was a horrible experience. It was just my mom and me. It was late at night. And like I said, he did that whole thing. I had to move him and get him in the car. And it was really scary. But we got him there. And while we were in the waiting room for the ER, he started having chest pain. So my dad had a condition. They called it I forget what they called it. He had an athletic heart, but he had something else that gave him these chest pains, but it was never anything. He had it his whole life. So I knew it was probably nothing. But they ended up admitting him to the cardiac unit because he was having chest pain. So they got that under control, found out nothing was wrong, and then they were going to discharge him. And I was at the hospital talking to the case manager. I'm like, no, I brought him here to get him into the mental health unit. And I had to fight and be his advocate to get them to put him into the mental health unit. So they did finally get him in there. While he was there was when I was introduced to the senior placement advisor. My mother and I went to look at senior living communities while he was in the hospital. And my mom was great about it. I mean, she knew she had to do something. And I had shown her a senior living community like a year prior to that, just, like, what the heck, let's go look. And she said, no, I could never live there. I can't live with all those old people. And I hear that a lot. People think they don't see themselves. But my mother and father truly were a young for their age, young looking, really good looking and athletic and all that. But this time my mom was different because it was a crisis. And she knew she had to do something, had to make a decision and move to one of these places. And then the other piece was we were with a senior placement advisor. So she respected him, and it was so interesting to watch her deal with him and interact with him. She wouldn't listen to me that way. And granted, I wasn't knowledgeable at the time, but still, just having a third party there is really important. The older people don't want to listen to their adult children.
Yeah, they want it to be their decision. It's their life.
Right. And we made it her decision, and I do this with clients. We brought her to 3 places, and it was totally up to her which of those 3. They all fit her budget. They all were places that could handle the care that my dad needed. And, so she made the decision. And so my dad ended up in the hospital for a couple of weeks. During that time, we packed up my parents and found a mover, and then we applied for Medicaid. And that was another thing. So the senior placement advisor referred me to a consultant and an attorney to help us apply for long-term care Medicaid, and also to a consultant to apply for VA aid and attendance. My dad was a veteran, thank goodness, because I don't think they could have afforded, they could not have afforded to move without both of these sources of money.
Right.
So in 5 weeks, we made it all happen. I mean, it would have taken me 5 weeks just to start touring places by myself, I think, because it's so overwhelming. Mm-hmm. So thank goodness my dad was stable. We were able to move him in when he was assessed by the nurse. She knew, she had his whole medical history. So she knew about the bipolar depression. She knew he'd been in the hospital, but he was stable by the time he moved in, and it was fine for him to move there. So that was a success, and my parents did quite well there, socially and in other ways. And my dad ended up getting ill, other types of illnesses, and ended up in a skilled nursing facility the last year or so of his life. But the mental health was stable. He never had another episode the rest of the time that he was alive, which was a few more years.
And he stayed on his medications.
Yeah. Okay. So that's another piece. So when he moved in, his medications were being managed by the assisted living community. So the director of nursing would order the meds. She knew when the refills were due. That piece was taken out of his control. Mm-hmm. So that was really, really important. And what I've seen, I was thinking about this morning, knowing that, we were going to talk about this. And I thought about all my clients that have had these issues. They all have gone off their meds, every single one of them, for whatever reason. And so I would say that it's really, really important to get, medication management under control. If you have an elderly parent or, a loved one, and you're not sure if they're taking their meds, you need to find out. That needs to be taken care of. And maybe you can prevent some of these kinds of things from happening.
Yeah, the regressions and the relapses into illness.
Yeah.
Yeah.
So I have a client right now who that's a big issue. And he's a little bit younger and has severe bipolar, but he's been treated. He was taken to the hospital because he fell, and his family called me. And I was trying to get the hospital to discharge him to a mental health facility, an inpatient facility program, so that we could get him stable before trying to find assisted living for him. Mm-hmm. While he was in that hospital, there was no psychiatrist there. They have only one psychiatrist on staff, and that psychiatrist wasn't available the whole time he was there. So my client was off his meds for 2 weeks. This is a guy with severe bipolar, and they discharged him to a regular rehab, skilled nursing facility rehab. One did not have a mental health license or emphasis or anything. So they were addressing the fact that he fell, but they weren't addressing the underlying causes behind any of it. And it was really, really frustrating. So finally, he did get into a mental health hospital, and I was able to help him find senior living. He's younger, and this is another challenge. A lot of people with the mental health issues, and sometimes substance abuse, and sometimes both together, are a little younger, but their brain has aged more rapidly, and they don't want to live with really old people. So they want to be within an independent living community, or at least the independent living portion of a community. And I get that socially, that might be the best thing for them. But if they're in that situation, we need to make sure their care and their medication management is taken care of. So this man, his family, after looking at assisted living with me, did not want him there. And then I took them to a place that only has independent because it met a lot of the other needs that he wanted. And they loved it right away. And that is where he moved. But I then referred them to a geriatric care manager. So she's overseeing his care. And I am so grateful that I did, because this would have been a disaster without that. So she has someone coming in to manage his meds. They fill his medication box. A problem he was having, he's so obsessed with his meds. When he's feeling good, he gets like, I don't need these meds, and he throws them out. So he was dumping his medication box. They were setting the box up, and then he would get a hold of it and dump it. So now they had to take it a step further. Someone actually comes in, gives him his meds. The meds are totally out of his reach and out of sight. And the care manager said to me, I think when he sees the meds, he might hear like a voice in his head coming from that medication box. She said to me, I don't know exactly how his brain works. Of course, we don't know that. But she gets that feeling from things he said to her, that like he hears it calling to him.
Oh, interesting. Yeah. Well, it can be so helpful, especially for families where, like in the instance of your mom and your dad, if your dad was a bodybuilder and he's manic or rapid cycling, how you were describing, he was rapid cycling. In one moment he would be agitated and aggressive, not posturing to harm her, but blocking, and which is a little bit threatening. And then the next minute depressed or lethargic or withdrawn, or I don't know what his symptoms were, but and so this rapid cycling is so unpredictable and scary, and then it can be hard for the person in your mom's shoes to be the one to say, well, no, you have to take your medicine, and then your dad posturing and saying, no, I'm not going to take my medicine. And or if your mom's even questioning, I could imagine if your dad is in this agitated state that he wouldn't be able to hear her. Right. And then what's so helpful then about having a third party also help to manage the medications is that it takes that responsibility away from the family. And so the family can focus on other things like their relationship and not the clinical pieces like managing mental health, a serious mental health condition with medications, right? Then there's a nurse to help with that. And so then it kind of removes that stress and stressor from the family system, which is so helpful, because I could imagine this tug of war between your parents if that kept up, if there wasn't somebody else. Or I see the tug of war with other families, not just about mental health meds really, but a lot of times about diabetes and diabetes management. And, you can't eat that food because your blood sugar is going to spike. And did you prick your finger today? And, all of that. And so it just kind of removes that level of struggle when there's already a lot of other stuff going on. So I like, it can be so helpful to have somebody assisting with medication.
Right. It really is important.
Now, have you seen any barriers for folks with mental health concerns moving into assisted living communities or personal care homes, room and board? Is it room and board?
There are different names for them. We sometimes just call them a 6-bed because they usually have 6 beds, but I call it a residential care home assisted living. They, if there's a really active behavior issue, the residential care homes are not the best place because there's only 6 people living there, and if someone gets out of control, it's really not good. So I don't usually refer to those places if it's an active behavior condition. And also, if they are elopement risk, somebody that wants to sneak out, care homes aren't the best place. So, but the bigger places, yes, there are barriers. I try to get my clients to tell me everything, and doesn't always happen. Sometimes it's like the last 5 minutes of a meeting. Oh, did I mention my mom was Baker Acted a few times? I'm like, oh no.
And just tell us what Baker Act is so our listeners know.
That's a Florida, I guess, term, and it's called something different in every other state, where they are I don't want to say forcefully, but I guess it is, that you have to make, it's not a voluntary admission to a
Right.
psych unit. They have to be, you are making them go to a psych unit.
That's right. It's an involuntary hold for a
Right.
psychiatric reason,
Right.
or the person could be gravely disabled in terms of not being able to care for themselves, or potential for neglect and harm,
Right.
and or having thoughts of harming yourself, or other sorts of things. But right. So right, it's an involuntary hold in a psychiatric unit typically.
Okay, thank you for wording that so well. But yeah, I had this client and she didn't tell me till like the last 5 minutes. Like, did I tell you that? I'm like, no, you didn't tell me that. So I have to tell the communities all of this. And then I say, do you think you can handle this? So their nurse does an assessment. Before someone moves into assisted living, they have to have a form filled out. In Florida, it's called the 1823 form. Their doctor fills that out with all their medical, not their whole medical history, but their current conditions and, especially their mental state of mind, and can they take care of their own meds, or do you suggest that we manage them, all of that kind of thing. Mm-hmm. So they get the 1823 form from the doctor, and then the nurse does an assessment from the senior living, from the assisted living community. So during COVID, that's been a real challenge. This client I was just talking about, his assessment was done virtually because they wouldn't let anyone come in to the skilled nursing facility to do the assessment, or the hospital. It was actually a mental health hospital where he was. So, but they did it, and they agreed that they could take him, and some places won't, so that's the bottom line. So I have another client today that I'm going to be meeting with his wife to take her to see places. And I had to reiterate, I sent the client information to 3 places, and then I did a follow-up email, and I said, I just want to make sure you read all my notes, because sometimes they'll just glance, they don't see everything. This guy is refusing to take his meds. Again, same thing. And this is a different client. And he's been combative, non-compliant. And I want to make sure you saw that. And please let me know if you think your memory care. And he has dementia. Okay, so this is another complication. Yes. So I'm looking for memory care for this new client who has bipolar and also has dementia. And he's non-compliant, not taking his meds. And he's gotten a little combative physically. Right. So I had to, I'm asking, do you think you might be able to take it? So one of them already said, no way. And the other 2 said, we will assess him and see if we can. Mm-hmm. So that's an issue. That's absolutely an issue.
Right. Because we know, well, at least I know the statistics for depression and PTSD, that it increases the risk for a dementia disorder. And so my guess is that also a bipolar disorder would also increase, because there's a depressive component. I don't know for sure. But I do know for sure around PTSD, chronic PTSD increases the risk for depression by 2 times, like wow. 2-fold increased risk. And depression also increases the risk for dementia. Mm-hmm. And so, yeah, it would behoove senior living communities with assisted living licenses to figure out how to navigate, or even memory care units to figure out how to navigate mental health concerns. And we know, even with dementia disorders, even when people don't have a history of bipolar or schizophrenia or combative behavior, that most people living with an Alzheimer's disease at some point become agitated. Right. That doesn't have to necessarily include physical violence, but it can include like pacing and restlessness and irritability and all sorts of physical behaviors that are unusual or atypical, right. Because the brain is changing and right. Yeah. And so I think it would really behoove senior living communities to kind of figure out how to navigate that, because it's important.
Right. And some are better at it than others, and they know usually what they can handle. And they'll so that the really important thing is that everybody's open and honest, that the family is open with me and then with the senior living community, and that there's communication going, and they figure out if they think they can manage this.
Yeah. And even the honesty from the senior living community back to you and the family, because it could also cause a lot of distress to move multiple times. So if the senior living community says, no, we're not sure if we can handle this internally, right? They might say that to each other, and then they don't give you that feedback. They say, yes, we'll give it a try. And then the family, the older adult with maybe a mental health concern or agitation with a dementia show up and move in. And a month later,
no, we can't handle this. You have to go. I've seen that happen. And then they're cycling through senior living communities because they're not equipped necessarily all the time. All of them are not equipped but are maybe not honest about what they can and can't do. Right. And so, honesty from both sides. So now one of the things for older adults and families that I've worked with that makes it hard to be honest all the time is stigma. So there's a lot of stigma around living with mental health. And of course, when we start to talk about even, I'm a mental health provider and I have to work through my own stigma and shame, right? With my own mental health history, with my family, having some like postpartum depression. I felt a lot of shame and stigma around that. And so, and I'm in the business, and I'm like an advocate for people and still I'm afflicted by the stigma and the shame. And so, and really have to work hard to create a new narrative for myself that this is human. There's nothing wrong with me. I have a condition or a situation that I need to manage. And so I'm wondering if you could speak a little bit about to the stigma and your experience associated with some mental health concerns for folks that you work with or in your life.
Sure. Yeah, I certainly, this is an important issue to me personally. As I mentioned, my dad had severe bipolar depression. I have dealt with depression on my own, myself. And I certainly years ago had a horrible experience about stigma. I was seeing a psychiatrist at the time, and I was living in a small town in Florida. My husband at the time was a physician, and the psychiatrist went to write my prescription. And he said, I'm going to write this in your maiden name because this is a small town. You don't want the pharmacist knowing that Dr. So-and-so's wife is getting psychiatric medicine. And I said, no, don't you dare do that. And I was in a depression at the time. And I went to get my meds and they didn't have them. I asked for it in my married name. And then I'm sitting there and I'm feeling, agitated. Like I said, I was in a depression and I'm going crazy. And then I'm like, I wonder if that doctor did what he said he was going to do. And I asked for it in my maiden name. They said, oh yeah, we have it. I was furious. I'm like, you're my doctor, my psychiatrist, and you're trying to tell me I should be ashamed that I have a mental health issue?
To hide it, and that I need to hide it from a pharmacist who is also bound by HIPAA.
Right. And I just was so beside myself. And I thought, if I ever take up a cause in my life, helping to reduce the stigma for mental health is going to be that cause. Yeah.
Wow. Thank you for sharing that. I'm sure there are thousands of people who could relate to that story of that even a mental health provider is perpetuating the stigma and the shame.
Right. I don't see it with seniors. Adult children don't seem embarrassed that their parents might have depression, but they might think it's normal. Oh, well, she's older. Of course she's going to be depressed. But there's not as much stigma, I don't think. The only stigma might be talking to a therapist, and that stigma comes from the senior themselves because they're not used to it. Like my generation, there's not as much of a stigma talking to a therapist.
Yeah.
And not even about medications anymore. That was like 20 years ago. But a lot of seniors, I don't need that. Yeah. I don't need to talk to her.
Yeah, I'm not crazy. Yeah, I definitely would get that. My average age patient is 86 for years and years, and I would get that quite often. Well, I don't think I need to see a therapist. Then I'll ask what's going on, and the person's in total despair and despondent and withdrawn, and needs some TLC and therapy and an antidepressant, and we work on it. And then at the end of it, they'll say, "Oh, I guess I did need this." But yeah, there is a lot of misinformation. And then the point that you're making about adult children saying, "Well, it's normal because my loved one is older, and isn't that normal as people get older?" And right, yeah, that's such an important myth to bust. Because of course, depression is not a normal part of aging. And also when we think that it is, then older adults don't get care that they need to alleviate the depression. And so I do wonder though, if So in your experience, it's not as much around the stigma for the adult child, like the baby boomer generation to the greatest generation, like the World War II generation. It's more, your experience is that it's more lack of information about what is typical with aging and mental health. Is that right?
Or that they can't get their parent to go to a therapist or a psychiatrist. That might even be more prevalent. I'm thinking about it now.
That makes sense.
Where the adult children say, I would love to get my mother to a therapist, but she won't go.
Yes, I hear that regularly. And spouses. So even older spouses, I've tried for years and they won't go. Right. Or, and children as well. And actually my most visited podcast and blog is my aging parent refuses to go to the doctor. Now what?
Oh, I have to look for that one.
Yeah. So that gets 100 views a day on my website just from Google or something. So yeah, that is a huge issue around how do I kind of build a bridge for accessing these services.
Right. And that's an issue with moving your parent to senior living too. That I know my parents should move, but they won't do it or she won't do it. That is a huge issue. Mm-hmm. And when there's a mental health concern as well, or even dementia, sometimes a guardian, sometimes you need to appoint a guardian to take over, because that is a huge issue.
Oh, yeah. And it's so difficult for families. And that is a topic I think we should I need to do another episode about, because guardianship and conservatorship is so complicated. And even if you do have legal authority over your older loved one, it doesn't make things easier. It just gives you authority. But it doesn't mean everything gets fixed. Oh, it's really challenging on families.
Yeah.
And so now, what recommendations would you give to families who are living with mental health conditions who are looking for senior living communities? So one recommendation was total honesty, so that you could really find a good fit.
Right. First and foremost is get the medications under control. And this is like way before you're looking for senior living. If you know that your parent is not taking their meds, I don't care what the meds are for, but especially mental health, make sure you get that under control in whatever way you need to. You might need to hire a professional who comes in and sets up the meds or gives them the meds, that kind of thing. So that would be the first. Then the second would be to seek professional guidance. See a mental health counselor, psychiatrist, senior placement advisor, because this is a tricky time to place someone. You don't want to just get out there on your own doing it. You'll spin your wheels. And possibly a care manager. So like with my client that I just placed, having that care manager has been critical. He would not have been successful without the care manager. And then consider inpatient admission into a mental health facility, hospital, rehab, before moving them to senior living. And an advisor like myself can help you figure all of that out. That's what I've done with clients. Second, you said about being open and honest. Then I would say to get follow-up care afterwards. You want to make sure that senior stays in therapy, starts therapy if they're not in it. And with telehealth, it's so easy now to get that to happen. And then also that a psychiatrist is managing their meds, or at least if it's an internist, someone that knows how to do this.
Yeah.
And to just stay on top of it. No matter when you move someone to senior living, you have to stay on top of it. No place is perfect. I tell my clients that all the time. The children or loved ones must stay on top of it.
Mm-hmm. What does that mean to stay on top of it? Stay on top of the managing the mental health care, stay on top of what exactly?
Keep in touch with the community. There's a director of nursing at the community. There's residential management people, whoever it is. Find out who, that's the first thing. Find out who it is. Who's your key person, a point of contact there. And, check in with them maybe a couple times a month if things are just good and smooth, but maybe definitely more often if there's complications. Call them, whatever, find out the best way. Ask, who do I keep in touch with? How do I keep in touch? And do it.
Yeah. Okay. So now I'm just thinking of another scenario where families might, one scenario, for example, are a few adult children who are helping their older loved one, and maybe they only have one remaining parent living, right? And so maybe one person sort of help, one of the adult children helps, and then 2 or 3 other adult children are around in different states. And I recommend typically that families kind of assign a point person in the family to do the communicating with medical providers and senior living communities and so on. Because if 4 family members start calling one doctor or one director of nursing, it becomes overwhelming for the system, for that director of nursing or the physician or the mental health provider, to constantly be returning family phone calls for the same person, for the same client or resident. And so do you recommend that families kind of also designate a point person in the family to be the one to do the communicating and then share what they learn with other family members?
Yes, that is definitely a good piece of advice. And I often give that to families. A lot of families have that already kind of. I'll hear from someone saying, okay, there's 4 of us and, I'm the one that does all the legwork and kind of makes most of the decisions. My sister takes care of all the insurance, medical insurance, this and that. My brother handles the finances. And then there's that other sister. Oh, she doesn't do anything.
Right.
Yeah. So that's how it kind of goes. But yeah, if they don't have that in place, either I suggested or the senior living community. I know for my parents, that was suggested to us. I have 2 brothers who live up north, and they got tired of hearing, the community got tired of hearing from all of us and said, okay, we'll pick one of you. We're only going to talk to one of you. And
please.
That worked.
Now, what recommendations do you have for senior living communities about working with or including folks with mental health concerns?
I'd say first and foremost is to recognize if you can handle that type of behavior and condition. And that should be an ongoing kind of conversation you have with your staff and your management. And to treat the person with dignity, to keep them safe while also being adaptable and creative. You often have to get really creative. And then make sure your staff is trained. If you are going to accept people with behaviors, that make sure your staff is adequately trained and understands various mental health and dementia conditions. And that it needs to be, there has to be some regularity to it, consistency. So the same people are dealing with that resident on a regular basis. You might have 2 or 3 different people because there's different shifts and different days off. I get that. But there has to be some consistency, and that they need to get to know that person. And that the medication management, of course, needs to be really well handled. Some places are doing it electronically where you have to enter it into a computer system. Everybody that deals with that patient, whether it's for med management or care, they have to log in and say they've done it. And I love that. I think that, and then there's no question, like the family can't say you weren't even in there. And some places have a key fob that they can actually look up and see who went in there because it's identifiable. And then the ongoing mental health therapy, make sure that the client has it. I like when communities have a therapist that comes into the community to see a variety of residents. That's always easier and helpful. But with telehealth, it's getting easier too. And then communicate with the family. I mean, that's a huge complaint I hear from families with any resident, and during COVID, if there was not really good communication, the families were very, very upset.
Yeah, I'm sure. Everything is so uncertain. The best is information. The most helpful is information, even if it's the same as yesterday.
Right.
Yeah. Well, Candy, thank you so much for all of this great information, just kind of breaking down what senior living looks like, the different types of communities older adults can live in, the different types of communities that can accommodate different conditions like mental health conditions. And I will say mental health is as human as physical health. And just as our bodies change and we might become more susceptible to physical illness, we can also, our minds and psyches can shift and change, and we can be vulnerable to mental health conditions. And so the more we're paying attention to that and providing support and resources and help for that, and then you're really serving as a liaison between older adults who are living with conditions and mental health conditions, and then and physical health conditions for that matter. or no conditions, and and senior living communities. And so I really appreciate that. And it means so much to me that you shared your own personal story about your dad and about yourself, and just this shared mission of destigmatizing mental health for everyone, and for this podcast, especially older adults who are often left out of the mental health system. And so I just thank you for the work that you're doing. And I'm so delighted to have you on the podcast today.
Well, thank you. It's been a pleasure. And I love supporting your mission. I have the same mission. Yes. And thank you.
Now it's your turn. Join the movement to include older adults in conversations about mental health and wellness. It's simple. All you have to do is subscribe, leave a review, and share this episode with others so that they can be part of the conversation too. One last thing, a special thanks to Jasmine Joyner, our Psychology of Aging podcast intern, for all you do. Lots of love to you and your families. Bye for now.
Lena, do you think aging is scary?
No,
No? Why not?
because it makes us happy.
Aging makes us happy?
Yeah, I want to be bigger and taller.